Welcome, everybody. Welcome to an off-schedule episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And this is a very spontaneous recording that happened after I received an email from last week's episode. So last week, I discussed pediatric pneumonias with Dr. Fatima Levent, a pediatric infectious disease doctor in Florida. And after that episode was published, I received an email from Dr. Jay Fisher, who's been on the show before. Apparently, he had a very similar case. It seems to me that there's some kind of trend for pediatric pneumonias, which I'd like to discuss on the show, because hopefully other doctors and clinicians can learn from that, and we can avoid bad outcomes for our patients in the future. So I decided to bring spontaneously Dr. Jay Fisher back on the show to discuss the case that he had. So thank you, Jay, for coming on the show in such a short notice. Just so people are aware, the episode we're going to relate to was recorded with Dr. Fatima Levent months ago, came on the air a few days ago. And then I heard from Jay, who is a fantastic PEM physician and who someone I consider one of the forefathers of pediatric emergency medicine in the US. And Jay, thank you very much for responding. The case you sent me was fascinating and directly related to what I spoke about with Dr. Fatima Levent. So I figured let's quickly, and you responded very quickly, record another episode when you can present this case and hopefully all of us PEM clinicians can learn from. Let me just introduce you, Jay Fisher, although I'm not sure you need much introduction. And you're going to have to help me. We did this last time. You are originally from
Pawtucket, Rhode Island, yeah.
Pawtucket. I can see the word on my screen. I cannot pronounce it. I apologize. And I know you did residency in Boston, followed by fellowship in Boston, and you were in Vegas for many, many years, almost 30 years. Now you work in California as a PEM physician, and you had a very interesting case of pediatric pneumonia. Tell us about the case, Jay.
I should clarify that this was not, I was the director there when this came in. It wasn't my case specifically. I'm sorry, I should have made that clear, but it was we had a small group. It was a colleague of mine, and so I knew about it a lot. So we did all quality reviews and things like that. So, but I know the case details quite well. And yeah, when I heard your case, it was essentially identical to, or very near identical, except that we had the great good fortune of getting a chest X-ray on the first presentation on our patient. So actually the first presentation was seen by an APP, which also is another little twist to this, but this APP did a wonderful job. This APP that I worked with many years was one of the best clinicians I ever worked with in the ER, just very, very good. But we had a case of a 6-year-old that came in with high fever. As I recall, it was in the midst of a sort of a flu outbreak in the community, but he came in with very high fever, 103.5 or something of that nature, and was a little tachycardic initially, but effervesced, and was not particularly tachypnic. I think initially was, but then went down to 20 or 24 breaths per minute, had a reasonably good saturation, nothing that would alarm you. And this APP, because of the prolonged fever, decided to do a really good workup with a chest X-ray and a flu swab and a strep swab, because we had been seeing. I know in your discussion with Dr. Levent, you discussed about group A strep and invasive group A strep, and that's one thing I have seen recently in the last decade or so, is this sort of coexistence of viral and pathogens in group A strep. But all the tests in this little guy was negative. Chest X-ray was clear, strep was negative, and flu was negative. So he got sent home after a period of observation with Tylenol, and then came back, I think it was about 30 hours later, with an episode of a slightly prolonged febrile seizure, maybe 4 or 5 minutes or something of that nature. It came in looking bad, and had no breath sounds on his left side at that time, and basically had near whiteout, as I think I showed you, on his left heavy thorax.
Yeah, and I'm gonna, with your permission, Jay, I'm gonna put those pictures in the show notes with a link in my website.
Yeah,
Because
they're de-identified, and I've obscured some of the facts a little bit so that it's anonymous. Yeah.
yeah, and I gotta say, I was very impressed. And just so everybody's who's listening understand, this kid had a normal chest X-ray the day before.
Yeah, I think I put that in the pictures I sent you too, right? I think didn't I send you the negative as well?
Yeah, no, I'm again, I'm just trying to make it clear for all the
Yeah,
people who
yeah.
are
The only thing
listening.
I,
This is
our business is ripe for retrospecting, and retrospectoscope, or whatever you want to call it. And if you look back, you can always find one little thing. And the only thing I would say is that maybe the left hemidiaphragm was a little higher than it should be in retrospect compared to the right. The right's supposed to be higher than the left, and perhaps they're about the same, or maybe the left is a little higher. But what are you going to do about that on day one? I don't think anything.
sure.
But yeah, it's clean as a whistle there, and then 30 hours later, white out.
That's really impressive. So your patient or the patient that we're talking about
Yeah.
was in the PICU for 3 weeks, required thoracotomy procedure, and just like the patient I presented with Dr. Levent, had a very very complicated course. And again, this is my anecdotal experience. When I was a resident, when I was a fellow, I don't think we saw that many bacterial pneumonias. It seems like now they're popping out of everywhere with very, very acute presentation.
Yeah, that I would say it's kind of fluctuated.
Uh huh.
'Cause I practice, remember, I started in the 80s, and so this was pre-Hib and pre-pneumococcal vaccine, and so we would see more pneumonias. I think I'd say in general more lobar focal pneumonias I saw in the 90s than I do now. But I do think now what you're saying is that these kids that maybe need to go in for decortication or VATS procedure and have these big whiteouts, yeah, I think that perhaps we are seeing more. It's potentially possible that we're seeing more of that now.
And they
Uh,
seem to be kind of sneaky, um, like my patient and your patient, just high fever, workup otherwise not particularly concerning for pneumonia, and then the next day terrible x-ray and terrible kind of clinical picture. And you are an experienced PEM clinician, PEM physician, Jay. Why do you think we see more of those patients now?
I really couldn't hypothesize, but I have to say though, if you have a spare couple hours someday, look up the work of Rich Bacher at Children's of Boston and Marvin Harper. I think he was on those papers too. Because about 10, 15 years ago, he did a lot of good work on pneumonia there, and I thought they found that 20% or so of when they systematically looked at clinical presentation, that they thought that 20% of focal pneumonia was clinically occult initially, and that it was a oops surprise infiltrate. And the question is, how many of those are viral and resolve spontaneously if you miss them? Those types of issues. I still think that the problem with our business is that we're always hunting for these relatively low frequency events. And it's very difficult to design prediction rules that will accurately identify those patients. And so it's always a situation where it's kind of a grace for by the grace of God, go I type of situations where we just occasionally get thumped with a tough case. And this is where I think benevolence is needed more in our line of work, that you can do a great job, like I think my APP did that time, and sometimes things happen and you can be absolutely great. And I remember in the 80s they used to talk about the missed MI was the big bad thing in medicine, the missed MI. And so we beat that number down with all these tropes and EKGs down to 1%. And that's kind of where we're at, I think, with kids now too, is that you can chase that number as long as you want. You're not going to get perfection. It's just the way it is.
Yeah, very, very good points. And one of the reasons, Jay, I started this podcast, and again, as obvious as it probably sounds, I really just wanted to educate other people and other trainees and share my experiences. I was very fortunate to learn from Dr. Rick Saladino, who I know you know, and some other great people. So you are an experienced clinician. every time I see a patient, any chief complaint, and that's why I teach the residents and now fellows, I ask them to look for and check for any red flags, and if there are none, I explain to the parent, mom and dad, I'm not sure why Johnny has symptoms XYZ, but it doesn't seem to be anything serious or surgical or dangerous. Do you think there are new red flags for pneumonia, things that we should consider on our HPI and workup and physical exam that we previously did not?
I think, I think this coexistence of viral infection or group A strep infection in the face of viral infection, that should be, that should raise some flags, although wouldn't have necessarily helped in this case with a negative strep, or a history of MRSA in the family, something of that type. I mean, all the obvious things that everyone knows, grunting respirations, lateralizing breath sounds. I think prolonged fever, as you mentioned, I remember having, and I go back to the family's worry that there's something that if the parents don't seem like what I call amplifiers, because we know some people are amplifiers, some are minimizers. If they're not amplifiers by nature, if you can tease that out, but yet they seem solemn, worried about something's different with Johnny, that's always a concern of mine. I trust my parents a lot.
I think that's actually a very, very good advice. So listen to the parents, as we always should do. But I like what you said about the amplifiers. Parents who are legitimately worried, they don't seem to be exaggerating. I like that.
Yeah. I mean, right. There's always amplifiers and minimizers. Yeah, I was thinking about this case a lot last night and yesterday when you and I were talking. And it's so hard with these cases when you're going fast too. Like it's the nature. The more I think about it, our profession is the only ones in the bunch, largely, except maybe surgeons or something, that we get into work and we say, bring it on 24/7, 365, no filtering, no parsing, no deferring, no kicking the can down the road. Just come on in, and I'm a doctor, I'm board certified, whatever, and I'll do this until I drop. Show me where else that's being done. Show me show me in what other line of medicine that's being done. And so all that's falling on us, and that's where sometimes we're always busy. We're always got too many patients. That it's a hard job.
No, I couldn't agree more, Jay. And that's why I admire all the people who do that and all the leaders in our field. People like you, especially, who've been training and teaching and working for so many years. Jay, thank you so much for coming on the show in such a short notice. Again, just so everybody knows, I usually recorded my episodes months in advance. The episode about pediatric pneumonia was published a few days ago, and within 3 days, Jay and I are meeting and discussing this. So I really, really appreciate your time. And Jay, I want to honor you and the PEM Rules tradition and give and play the outro of your choice. And I know you like AC/DC. I got to be honest with you. I woke up at 6 in the morning and I looked up AC/DC songs and I said, I got to learn something by AC/DC for Jay. And I don't know the name of that guitar player. What's his name?
Oh, yeah.
He has a German-like name.
Yeah, Anson or something, or Ann. I don't know either. Yeah.
I cannot, this is pushing it, really pushing it. But I've been working all morning on a slightly easier version of Thunderstruck. So I can kind of play the intro for about 5 seconds, and then just the acetylcholine in my neuromuscular junction just kind of gets depleted. So that's all I can do. But I definitely want to do that for you. Thank you very much for coming on the show. It's a great case. And I hope all of us PEM clinicians can learn from this so our patients have better outcomes.
Yeah, great work, Yaron. I'm a big fan. I'm always listening. Keep up the great work.
Thank you very, very much. Thanks a lot for coming on the show.
You're welcome.
And that is it for today, guys. Thank you very much for listening to the show. Last minute episode, as I mentioned. Thank you very much, Jay, for coming on the show. Hopefully we can learn from these cases. Acute pneumonia, severe acute pneumonia is out there. Be conservative, be aware, and best of luck to all of us who practice, like Jay said, day and night under all those circumstances. If you're interested, look at the show notes for a link to my website with pictures of the patient Jay discussed the day of the presentation and the next day. Chest x-ray that is very impressive. As usual, thank you very much for listening to the show. Please check out PEMRules.com and check out my column on EP Monthly. I appreciate it. And here is 5 seconds, no more, of Thunderstruck, especially for Jay. Hope you like it, Jay. Thanks again.